Okay, we'll get started in about 1 minute, okay? Thank you all for joining us Monday after Thanksgiving. I'm sure you're still recovering. Hope you had a good one. Okay. Okay, is there anyone that missed that first module? Otherwise, I'll introduce myself if there are people who missed it. If you could raise your hand or put it in the chat, that would be great. So we'll get started. I'm Dr. Tracy Beal, and I work for the Los Angeles County Department of Public Health as an advisor. But prior to that, I worked in hospitals and in health plans and pharmaceuticals. But the last decade, I worked in a mental health capacity, running a mental health hospital and also running a division of mental health for one of the hospital systems called Dignity Health. So I'm pretty versed in certain things about mental health, not a clinical expert, but took a lot of training in mental health first aid. And I appreciate all of you who are interested in helping support the mental health outreach by becoming an ambassador. So what I'll ask is that you put your name in the chat so I can make sure that that third module that we do, I get you your certificate as well as email you the presentation and recording today. So if you could put that in the chat, that would be great, and we can get started. So the whole purpose of the Mental Health Ambassador Program, thank you all for starting to put things in the chat. So put your email, like I said, and I will get, make sure at the third one you get your certificate of completion. So again, the Mental Health Ambassador Program is really to help support efforts to improve mental health support for people. It's not to make a person a clinician. It's not to change how work is done in mental health. Is really to help support, whether it's family members, friends, or people you meet through your work that you do today. Is really to help support how we go about supporting people who need mental health help. Okay, so today we're going to go back for a moment and we're going to cover, let me stop sharing for a minute. We're going to cover, go back and kind of look at what did we do last time, because sometimes it's hard to remember what exactly did we cover. Thanksgiving was a long time ago, it seems like. So let me change the screen so you all can see this. So the certificates, like I said, put your email in the chat, but the key takeaways from last time, I'm going to let you all tell me what you remember. And then that real support framework, how you engage people who may have mental health needs. We're going to cover that again, just so you can remember all the details about it. And what's different today is we're going to go into what we call some more severe conditions in detail, because sometimes you may be able to sense a person might have some of these, but even if you don't, it's helpful to know what the differentiators are, how we look at, bipolar, schizophrenia, dementia, and that there's different types of dementia. And that third module, we're going to be doing some case studies, and I will show you all these resources that we have to help support any referrals that you need to give people. So let's start with what happened last week. You may recall this quote here, which is basically that mental health is not a destination, but a process. It's about how you drive, not where you're going. So you as a mental health ambassador are considered that person, like I described before. You're doing driver's training and you're sitting in that second seat helping a person to steer. You may not get them to perfection for parallel parking or whatever, but at least you help them navigate to get to a different place from where they are. So that is the entire point. It's not to solve the problem. It is to support assistance. And sometimes I know initially I felt like a failure, but what I was taught was any help is better than none at all. And you can't predict how people will respond. So I'm going to pause there and let people speak up about whatever they remember, any key takeaways from that first module where we talked about the role of the mental health ambassadors and how you engage with people. So I'll pause there and let anybody who wants to speak just go ahead and get started. Okay. You don't have to raise your hand. I'll just let the first person speak. Anybody remember anything?
Hello, good morning. It's Marquis.
Hey, Marquis.
So, I know last week we were talking about pretty much providing resources to people that we think are in, they said, are in like crisis mode.
Mm-hmm. Yes, that's right.
I remember that. I also remember that we discussed that sometimes you can't always reach out. You can't always reach them, but you can still put forth the good faith effort.
That's great. Yeah, so it's all about the E for effort, not resolving the problem. Anyone else remember anything else? Because that's pretty much the tone. Okay.
Hey, this is John Chisholm. The
Great,
whole
John. Go ahead.
the real support system, like that, stuck in my mind. Like that is like having the steps to actually do something was super helpful.
That's great. And we are going to go over that one more time, because even though it seems like it's complicated, it's something that once you get it, you'll remember to follow those steps. So thanks, John, for bringing it up. Anyone else before we go forward? We need one more. I try to get people to give me 3 takeaways, just one more from anyone. Okay. Well, the one thing that stuck out to me was people came forth and shared some of their personal experiences with mental health. And I think that's brave. I was very candid about what happened and how did I decide to learn more about mental health. And that's a sensitive spot, but I think it's important for people to know, unfortunately, mental health challenges are pervasive. It's not, something that just certain people get. So just want to make that point. But let's shift now and go to the real support framework, which is how you engage with people to deal with mental health issues. So first and foremost, you have to recognize there might be a situation or problem, and then you try to engage them. And we're going to do some role play with that in the case study part. And then you try to do the A, which is assist them. But the most important thing to take away, if you remember nothing else and you don't remember all these steps, is to listen, which is the big L, and then to try to give them some type of signs or signals or support. And if you can, and sometimes you cannot, is to follow up and see how they're doing. But you may not be able to do that. That's why the listening can make the difference. I can't tell you how many times I was on a crisis hotline and somebody was literally gonna jump, and just listening to them sometimes really did help. Wasn't always the answer, but remember, the whole point is to engage and give the effort, not necessarily to resolve. So R is for recognize, E is for engage, A is for assist, L is for listen, S is for signpost, and F is for follow up. So this is the framework. And remember, you're going to get these slides at the end. Go ahead. Somebody was talking, was that Thelma or who? I don't know.
Okay. It wasn't me. I thought it sounded like Reverend Anisha.
Oh, Reverend Anisha, were you speaking? No, maybe not. Okay. And just to reiterate, this was the visual that shows you the 6 steps that we just covered, the real support framework, where you recognize, engage, assist, and listen. And again, if you do nothing else, just listening helps, because most of the time people in mental health crisis or who are challenged feel like they're not being heard. And they want someone to listen to them, or they may not feel like they want somebody to listen, but listening is one of the things we've shown, evidence-based shown that it really does help. So we went through some of the different types of mental health conditions last time. We talked about depression and anxiety, and when people grieve and grieve so hard that it triggers depression and anxiety. We talked about drugs and alcohol and self-harm. And today we're going to talk about a really hard subject, which is suicidal thoughts. But I want people to take away some positives from this, because you may be able to understand when people have these thoughts. And I'm going to actually but talk about a couple of celebrities that came forth and have given interviews on their suicidal thoughts, only because people were surprised to see some of the folks who talked about it. And then we'll go into some of the severe conditions that you may have heard of, but you may be able to recognize a little bit better after we talk about some of the ways you'll know what these are. So the first one is suicidal thoughts. And this is a really big one, because what happens is people who have suicidal thoughts think killing themselves may be the only way. They feel so desperate, they want to kill themselves. And the thing that's interesting is they may or may not attempt to communicate with others that they're in pain and want to kill themselves. There is not always a note. People may not always see some of the signs and symptoms. And one of the most interesting things that we've noted is that most people who commit suicide have pre-planned it. Whether or not they leave a note is a whole nother matter. But for the most part, particularly those that survive, they told us how much time and effort they put into planning it in their minds, even if they didn't say anything. And one of the most common things we noted about those who did that, when we talked about symptoms, they may or may not talk about killing themselves, but sometimes they talk about not wanting to go on. And also they may suddenly engage in high-risk activities. And what I mean by that is we've seen people be sexually promiscuous, do all kinds of things that they normally don't do. And that's a symptom. They engage in these activities that they normally wouldn't, or they're the opposite. They get agitated easily, and they may be sleepless or withdrawn, and they may increase substance abuse, or they may not. That's why suicidal thoughts are so hard, because unless people verbalize, you have to watch these quiet behaviors, we call them. And the next thing is, what is helpful? You can actually ask them if they are feeling so sad they feel like killing themselves. It's okay to ask people that. I don't know if it's appropriate, depending on how well you know the person, to actually use the word kill, but ask them how they're feeling. Maybe you can ask them if they're suicidal, if you're comfortable doing that, and if you feel comfortable that the person might engage in that. But for the most part, we just ask them how are they feeling, and just listen to them and help them. If they're uncomfortable talking to you, ask them if there's anybody else they feel like they could talk to. Just letting them talk, like I said, it's evidence-based that it decreases the chances of it occurring. What's not helpful, I've been on calls and heard people in the background telling them that suicide is wrong, it's against this, it's against that. That seems to drive people towards it, not away from it. And making that person feel guilty about their decision to think about committing suicide seems to drive them closer to doing it, as opposed to the opposite, when people are trying to reprimand them about it. And dismissing it as if it's a cry for help, being very dismissive about it, is when we've seen particularly adolescents go more towards it than away from it. So we tell people, don't try to take control, listen first. And if you see people doing certain things, don't label them. Ask them if they're okay. Ask them maybe why they're feeling the way they're feeling, or if there's something they think you could do to help them. That's the way you engage with them. Otherwise, we've seen people move people towards it, not away from it. And the last thing about suicidal thoughts is to encourage them to speak to a professional. And there might be an immediate need where they may be in such a threatening situation, you do need to call medical help immediately or triage them. I've had to call ambulances or psychiatric emergency teams or even the police to do a welfare check on someone when we thought they were in a certain situation. And if you feel that way and your gut is telling you to do that, then you should do so. And like I said, don't hesitate to call for help. I've had people call and say, I've gotten all the pills, I'm getting ready to take them. Well, we go ahead and dispatch someone when I hear people they've already done their planning, they've got their pills from somewhere and they're getting ready to do it. And it's okay to say that I'm really worried about you, or can we seek help? Sometimes the I may not help. It may be, can we seek help? And it is okay to get their consent to help support that effort. If they don't want help, I think you still need to try to triage to get them help, only because you're in the moment and any help is better than none at all. So I'll pause there to see if people have any questions or, thoughts about that at all. Because it's a hard thing because people may not talk about it, but usually the younger kids tend to leave what we call breadcrumbs. They may leave social media posts, they may leave notes, they may show certain behaviors or withdrawal. So I'll pause there to see if anybody has any feedback or comments or experiences in that arena.
Hello, good morning. It's Marquis again.
Go ahead. Mm-hmm.
So as you know, I do work in the ER, and I do a lot with patients who are in a crisis.
Mm-hmm.
And I know for me, it's always been really helpful to be honest. How do you say it? Not necessarily honest, but pretty much straightforward with somebody. In a very kind of calm, gentle demeanor. Because when you're like going around the problem, it doesn't really address the problem. It's kind of like you're tiptoeing around the reason why they're there. Yeah,
be upfront is what you're saying. That sounds good.
Right. Be upfront and just be empathetic.
Yeah. And Wesley, looks like you have your hand up. Go ahead.
Yeah, I was just gonna say,
we can't hear you, Wesley. Can you turn your volume up or speak up a little bit?
I'm sorry, are you able to hear me now?
A little bit. Let me see it. Okay, I put mine on high. Go ahead now.
Okay, what I was gonna say was that similar to what you had been talking about with, looking more for actions rather than words sometimes. I actually used to work with, I used to volunteer and take care of a youth group for a group of like teenage or adolescent boys. And we were always taught, sometimes if somebody's in a mental health crisis or if one of them needs our help in that way, it's not always going to be as easy as them coming up and saying they need help. It can sometimes be little things that we're going to have to make the conscious effort to look out for and notice those behavior changes or those, the patterns, and just kind of take that initiative to reach out to them, because it may not even be something that they're consciously realizing themselves, and or they might be and they're trying to conceal it from adults, and it's just kind of a thing of, not always something that's going to be so overt.
Yeah, it sounds like what you're saying is we need to take the initiative to reach out, particularly when it's younger people, because they may not want it known. So let me go to Thelma. Looks like you do have your hand raised now. Go ahead.
Yes, there was a situation with one of my very close friends and her daughter, and I followed her on social media to discover she had suicidal thoughts, on her mind. She didn't allow her mom to follow her. She had her mom blocked, but I'm like that cool auntie to her. But it really put me in a situation. What do you do? She entrusted me to see these things and know these things about her. And, but obviously she didn't want her mother to know. How do you begin to share that kind of information or seek help for somebody who's obviously asking for help in an indirect way? I was so troubled by that. And I did decide to share that with my friend. And, but what are the second steps?
Yeah.
I mean,
I think if a person's in crisis, you have to breach confidence at times and go to someone who they know. And the conversation is, have you seen your person, family, friends, social media posts lately? And at times I've actually sent a person a link because they weren't paying attention. At other times, I noticed some people block their parents and people who they don't want to know.
Right.
But it is worth disclosing. And one of the most startling statistics that I found is lately with all of the shootings, mass shootings that we've seen, almost every single one had posted indicators on social media. And they were not closed, they were open and people saw it and everybody just kind of remained quiet who were part of that network. So even though it's a hard thing to do, indicating that, hey, there's some things on social media you may see, even if we screenshot it and call them and tell them, it's hard to do this stuff by text and email. But when it's that alarming, I tell people, it's worth intervention, even if it's a hard shift. I don't know if that helped or not, Thelma.
Yeah, it did. I did share it with her, and she spoke to her daughter, but she kind of drew a little bit more. For some reason, she wasn't comfortable with sharing, with their mom, but she allowed me to see these things. It was just it was a little bit uncomfortable for me.
But it's so worth it. And I understand that. And this is not easy. That's why we're going over this, because the suicidal thoughts are hard, particularly in younger people, because that seems to be their first indicator. But at the end of the last module, we will give you resources. I've actually even done a 3-way call on a hotline with people. But you don't need to go that far. It's just, I could not get that person to call themselves. I called for them. And I just stayed on the phone because I knew they had gotten the pills. One person had gotten the gun. It was like, and I'm not even physically with them. So you do what you think might help. And like I said, it doesn't always help, but you feel like you tried to do the right thing. That's the best that you can take away from being an ambassador. Okay.
Okay. Thank you.
Okay. So the next condition I'm going to talk about, but let me go back to suicidal thoughts. One of the most startling interviews about suicidal thoughts that I saw was Halle Berry. When she got divorced, she said that was, and I don't know if people knew she was a diabetic as well, and they don't know if that helped trigger. Sometimes diabetes, depending on the chronicity, can help trigger, can accelerate or exacerbate depression. In her case, she said she felt like a total failure after she got divorced, and she was headed down the path. And she notes she's been in and out of therapy for about 30 years, but she gave a full interview. You can Google it and find it. And it was surprising to most people because they said she's a very vibrant person when you work with her, and they were just so surprised to hear during that time she felt that way. So suicidal thoughts are not, one person or another type of person. It's anyone can have them. The next condition that I'll talk about that's very pervasive these days is bipolar disorder. And one of the celebrities that you might think of when you think of bipolar is Kanye West. He is a classic bipolar person. He's given interviews when he wasn't in one of his states. And it's fascinating to hear him acknowledge, the medications, what he needs to be doing, and then he doesn't do it. And if you think about Kanye West, he has ups and he has downs, and he has a lot of manic episodes that sometimes manifest themselves in his behaviors, very unpredictable mood swings and behaviors. And there is not like, there's bipolar 1, bipolar 2, there are gradations and types of bipolar. So there's not one bipolar. Another person who's bipolar is a Saturday Night Live star, ironically, who was recently Kim Kardashian's boyfriend, but is Davidson, that's his name. He's from Saturday Night Live, but he did an entire movie about his bipolar disorder. And it's fascinating to watch, just to see how bipolar is, where you have these ups and downs. And one of the symptoms of a bipolar person that's really kind of common is this overactivity. They are very exuberant. And then on the other hand, they have very lows, like they may forget to do the basics. They don't eat, they don't sleep. They may not even, take a shower because they're really focused in a certain place in their brain. Some experience hallucinations and visualizations that they think are real. I think in Kanye West's case, he talked about these visions of God and how he made these songs. So, but the one thing that happens during either the highs or the lows is poor judgment. They say and do things that are erratic. And like I said, those severe mood swings are a bit challenging. And what's helpful is, again, that listening and talking, particularly when people are manic, trying to be calm and patient, and learning what triggers them. If you're around that person often, knowing what triggers them, like some people, they say family dinners trigger them, certain people trigger them, places, food, certain things may trigger their manic episode or their depressive episodes. And it's hard to know. What's helpful is trying to balance listening to them and trying to support knowing they need help. And it's not for us to be clinicians and diagnose. I'm just giving you some of the symptoms. So if you see people who are behaving like this, you may know it's not a one-off. These are things that happen sporadically. Anyone can have, a sad moment or time, but these are sporadic and they are persistent, where they're up or either they're down. And sometimes the ups go on for so long. When they finally hit the low is when they may go into that suicidal thought process. And that is one of the major concerns about people who are bipolar. When they hit the low, when they've had a prolonged manic episode, sometimes it can be a very low. And there may be people who, what we've seen is those same people might also have attention deficit disorder, but they also have lows. So usually attention deficit disorder, people, not all of them, not even a certain number of them, but at times there are people who have attention deficit disorder and they may also have bipolar, where they have they get very depressed at times. But that's just one of the conditions we've seen at times that's affiliated with bipolar. And at times it can be a precursor to bipolar. What's not helpful is reacting to these people. Some people get very frustrated when they see these folks with the manic episodes and they can't calm them down. I tell people, get out of the way and just try to talk to them or listen to them and just say, are you okay? Let me see if I understand what you're saying. And it's interesting, one woman who I know who is bipolar, she would always see snakes. She would go out into her yard and then she'd have these hallucinations about snakes. So that was a trigger, which means that not going in the yard, but going outside was a better thing for her to do. And she did get psychotherapy to do that. So talking her through, I think I talked to that woman about 8 times, and we actually sent people over and did a welfare check for her. And that's how we finally got her into therapy. It took us about 5 attempts because she was in a space with her hallucinations with those snakes that she didn't really want to be out of. So what are the signposts? How do you guide the person? It's, like I said, referring these folks to a professional. The medical part of referring them to a professional is really important because they may have underlying conditions that a lab test or a blood test may indicate. And I know in some conditions, like people who had MS, those that had a stroke, some had Cushing's disease. When we did the medical underlying condition that drove them to this, it was interesting. So having that clinical intervention is important. And we always triage folks who say anything related to suicide, even if it's a joke, to a hotline or to that 988 number. And one of the things that's very helpful is if you know someone that's supporting these people, or if you're supporting those folks, is to list and to document what you've seen. Because it's hard when they go into the physician's office, if you or someone they know is going with them, to help with the diagnosis if they don't have some of the descriptives. And it's hard for some of those folks, once they've had these episodes, they can't remember what went on, whether it was depression or the manic. So I'll stop there and see if there's any comments or questions, or if people had experiences with this? I know someone had earlier, the first module mentioned they had experience with bipolar. Is there any comment or anything else before I go on? Okay. Okay, well, bipolar is hard, but like I said, there are quite a number of celebrities, and I bring them up because they're so visibly going through this. You can see the bipolar pretty obviously. The only person that people were surprised about that was a celebrity that was diagnosed with bipolar, and she's given quite a number of interviews. I think it was Mariah Carey. People didn't necessarily see her depressive state. They only saw the manic state. So they were a little surprised by her. But Kanye is a classic, more what we call a classic bipolar type. The next condition we'll talk about is schizophrenia. And schizophrenia is hard because people who do have it, they don't want to come forth. They don't want to be labeled. They don't want to talk about it. What's interesting about schizophrenia is the definition is very ambiguous because it's kind of like a collective of different symptoms. And you really have to have a clinical diagnosis to look at the chemicals that show up for schizophrenia. And what a person with schizophrenia has is they look at the world differently. They have what we call an abnormal interpretation of reality. And it affects every aspect. It's not just their feeling and thinking, it's their behaviors. And it's more common in males and in certain ages 18 to 35. And what they found by all the clinical trials and research they've done is there is customarily or often a link through family lineage with schizophrenia. For example, one of the people that I know that has it, his uncle had it, but nobody ever talked about it. So at times there's a lineage that people don't necessarily know in the family or talk about, but we found that to be quite common with schizophrenia. And I will give you a celebrity that has this so that you can think about how their condition is. And there is a movie called A Beautiful Mind, and a famous scientist, John Nash, who was a mathematician. And he was portrayed so well, that movie garnered a lot of awards. But he visibly, throughout the entire movie, they showed a person with him at all times. And what you realized later on is that person was not real, but he was convinced that person was real. And that's how his reality worked. He had this person with him at all times, and he saw the world through that secondary person. And he was brilliant, absolutely brilliant. He won a Nobel Prize, but he would have these delusions and hallucinations. He got married, and that wife intervened when she saw that he would overwork himself into a frenzy. And he would have all these hallucinations and be totally impaired. He couldn't even function. And he would not even have eye contact with people and his fellow colleagues. And he would shirk and laugh off any comments people would say about his behavior. And he actually attributed to his brilliance. And he got away with it until he got married, and she noticed that it was just so off the cliff, that his behavior was just so erratic. And the best that can be done, if you see people with these extreme interpretations of reality and they're totally convinced that, and they stay in that space for prolonged periods, is to talk and listen again and give them encouragement. And if they are suicidal, which sometimes they get to that point, that common age range is ages 16 to 30. So this is a red flag if they start talking about suicide, but also just supporting them and talking them through. But remember that age range, and remember it's male, but it's also females and others, but males tend to be dominant in the schizophrenia realm. What's not helpful is I've heard people shouting at them to stop. Particularly some of them can be screaming are just describing their realities as if it's real. They're totally convinced. Like one guy, he packed his bags and would tell us the world was ending over and over again, and we got to go to the bunker. And he would so graphically describe this world that it seemed real to him. And you have to listen to them feeling like it's real and talking them through it accordingly. And the signpost, what do you do? Really, the medical referral, if you think a person has schizophrenia, is critical, and doing it early. What we found is a lot of people try to push it off, and they see this in their kid or a family member, and the early intervention is critical. This can be managed well with medications, but the lab and brain tests, the brain scans are critical. And a lot of people with schizophrenia, when we talk about the homeless and people self-medicating with drugs, we have seen a lot of people who have schizophrenia tend to be on that edge of on that end of doing that. When we've done tests with some of the homeless in the community. And what's been very helpful is a lot of the clinical trials that have demonstrated what medication works for the different age groups, types, and that has been extremely helpful to people who have schizophrenia. And on occasion, we've seen kids with it, but it's very rare. And there are some films about some of the kids that had it, and at times people thought they were just bad kids acting out. But when you saw the film, you realize that it's beyond a momentary outburst or an occasional, traumatic episode. It's really persistent and prolonged, and it's so hard to control that they need to engage and get some help. So I'll pause there and see if anyone has any question or comment about schizophrenia. It's not something people like to come forth and admit, so I'll let John talk. Go ahead, John, I see your hand raised.
Just hearing you talk, it has made so many things clear for me in my childhood. I had a friend that I grew up with who used to talk about his friend Paul and how his family treated it, and come to find out his grandfather and a couple uncles struggle with this because they treated it like they never made any trouble with it. And whatever he said, that was like, okay, that's they just accepted that reality. And now he is for sure homeless and out there in the streets, and wow, like so apparently he is just a very stereotypical case of schizophrenia.
Yes, in fact, the mental health disorders are so pervasive in the homeless. In some places, they're actually creating homeless mental health clinics through street medicine. I know Wisconsin is actually creating a separate psychiatric support hospital just for people in that situation. So it sounds like if we really did the right thing for the right reason with the homeless, a certain significant percentage would show up with mental health disorders. That's why their activities of daily living and some of their behaviors really match these descriptions so well. But you can see this, the sad thing is a lot of people in the family, you just kind of turn your head or we try to ignore it. But the truth is, if they could get help early in some way, and some people, it takes multiple attempts to get them help, but at least trying does help. Okay, so I'll go to the next one, which outside of schizophrenia, the classic one that I think about really is that guy from that movie, A Beautiful Mind, that he was so convinced a person was with him. There's also one other person with schizophrenia that everybody probably knows about, the famous painter who he cut off his ear, Van Gogh. He was known to have had schizophrenia. He had highs, he had lows, but his paintings were so vibrant when he had his hallucinations, and he would hear voices, he would paint so vividly, but he could not function on a daily basis. And this is one that people are familiar with, dementia. And we're going to go into more conversation about dementia because it's so pervasive. And it's really pervasive in Black communities first, Brown communities secondarily. And we'll talk about some of the reasons for that. But dementia is not just a quick hit losing your memory or forgetting from something. It's profound impaired memory. It interferes with daily living. And there are people who do get it that are earlier than age 65. There's a famous coach for a women's basketball team who got it. It's rare, but it does happen. And there are certain types, two main types. One is Alzheimer's disease, which people know about. And the other ones are like vascular dementia. If a person has had a stroke, sometimes it impairs their ability to remember. And that's what we call vascular, meaning it was exacerbated by another condition. So we'll talk about those in more detail because this is so common. And also a person might have diabetes or some other conditions that may lead them to have vascular dementia, which is why we believe, because stroke, heart attacks, all of that contributes to vascular dementia. That's why we believe it's so much more pervasive, in addition to all the stress of daily living in the Black community first and the Brown community second, because of all those other conditions and the environmental factors, in addition to some of the disparities in the healthcare system. So vascular dementias are quite common, but Alzheimer's is like the number one. It's the largest bucket of all dementias. So memory loss, everybody knows about that. But the difficulty thinking and processing information, my father had Alzheimer's and then he had dementia. And the test that they gave was to draw a circle. Well, he kept drawing a line. So you can see how your brain is disrupted. It was trying to make the connection, but it couldn't. It kept drawing a line, even though he would concentrate hard and he could not draw that circle. So that's the way the brain is like, the way I would describe it is like scrambled eggs. Your brain can't make the connection. And he would try to finish certain sentences and the language would get impaired, meaning the verb would be at the end. And he would also pack his clothes and try to leave. And that means your judgment is impaired. Like, where are you going? He thought he had to go to work and he was retired. So your judgment is impaired. You may digress to earlier times in your life. And the symptoms vary by the type of dementia it is. But really the impaired judgment, they may go outside naked, or they may go outside without their coat on, or like he would walk 5 or 6 miles and just keep walking. Where he was going, he would tell people he was going to work. So those are symptoms that are pretty common. As it gets worse, they may, he never forgot our names, but he would try to go places. What's helpful, the number one thing is patience. It can be very frustrating. Like I've seen people try to climb out of windows. Sometimes they can get combative as their symptoms get worse. And they're very frustrated with people trying to intervene with their independence. So you have to take a slow approach to intervening, meaning you can't just take their car keys away. You have to kind of evolve to that in a different way. It took a lot to get his car keys away from him because he loved his truck. So also, when we would say the word dementia or whatever, he had no idea what we were talking about. So they say when you're dealing with people with this, you need to keep it simple. Like, are you forgetting a lot? Do you remember this? Do you remember what day it is? Do you remember this person? We would show him pictures. So those are the things that are helpful. And also, don't abruptly change the lifestyle. Like we color coded his food things so he would know what was lunch, what was dinner. So it was incremental, so he still felt in control and he could do things for himself. And doing wayfinding, like he would forget where the bathroom was and go to the closet. So we labeled things with visual icons until he couldn't remember the icons. What's not helpful is, like I said, reprimanding people. Why are you going outside with no coat on and it's, snowing? Or using medical terminology, or making them feel like dumb by not being able to remember something. And a lot of people who have dementia might live alone at times. So managing it alone is challenging for you as a family member or the caregiver. So I tell people who have this, get support, even if it's a support group. of any kind, because handling this alone is a lot for any individual or a family. So get some support, because it can be for a prolonged period of time and it can be exhausting. So I tell people, refer them, you have to get a brain scan that shows the Alzheimer's to get a confirmed diagnosis. Otherwise, Medicare and all the resources will not come forth. So it's important to try to get that brain scan. My father was denied it when he had Kaiser, but he went wondering. And so the hospital picked him up and they did the scan. So he got the scan by default. So try to get that scan and get a PCP who's amenable to getting that scan, because it's not cheap, but it's important to get that diagnosis as soon as you can in order to entitle them to the resources. And most of the people who have it may not know they have it, and they may be very resistant to treatment or just being resistant to their independence being eroded. So I'm going to stop there and see if anybody has experience with this or would like to share anything about it or have any questions or comments. Because dementia is quite pervasive. Okay.
Hi, Dr. Beal. This is Lisette. Yeah, I just want to share also that, yeah, like my grandfather, I remember that we weren't sure if he had Alzheimer's or dementia, and but he was in Mexico. So like, yeah, I can definitely relate to that.
Yeah.
So, like running in your family. So it's just like, even your loved ones that are trying to take care of you, like you're trying to figure it out as you go with the help of the doctors or nurses.
Yeah, I think getting help and support is important. Wesley, you have your hand up. Go ahead. Thanks, Lizette.
Yeah, I just also wanted to share something similar. What you were saying makes a lot of, sense in the different, the process of dementia and everything. My mother has been suffering with late stage dementia, so it's definitely something that I've been seeing and witnessing and being a caretaker for. And it's definitely, interesting to see kind of like hearing you talk about it and seeing the parallels and, what she's been going through. In real time. So yeah.
Yeah, and I'm going to go a little deeper. Thanks, Wesley. I'm going to go a little deeper into this because I had to learn so much about it by default that I think it's helpful. Some of the findings that I had, because I ended up researching this more than I wanted to. I ran an Alzheimer's unit at one of the hospitals too. But I want to make sure people understand the difference between Alzheimer's and dementia, because I hear the two terms used interchangeably. So I wanted to clarify that dementia is the umbrella term. And I put this visual umbrella up here for a reason. It's like everything in the kitchen sink falls under the umbrella of the dementia. It's not one disease. It's everything that impacts a person's thought processes and memory. So there are different forms, and Alzheimer's disease is one of those forms. So Alzheimer's is the most common, and it's the one that people kind of know the best about, people forgetting and not being able to remember people, places, or things. So it is the most common, and it's the majority of dementias. But like I said before, so dementia is an umbrella term. Alzheimer's disease is just one of them. But the vascular dementias are the ones that people don't recognize as much. Like I said, people with different diseases like diabetes, or they've had a stroke, or in the case of someone I know, they had a accident that was a full frontal crash, and it impacted their, they didn't have a stroke, but it did impact their memory. So this can be vascular as anything that really impacts you in that way. The one that I'm most familiar with is what my father ended up being diagnosed with, which was Lewy body dementia. And this one, there's usually like a 5-year lifespan. And when a person has Lewy body, it starts robbing them. Like my father was very healthy. He was a walker, runner, exercise person. He was very muscular. It robbed him of his ability to even walk. It takes away walking and physicality and it just robs them of their organ structure over time. So by the time within the 5-year span, most people can no longer walk. They're usually in a wheelchair. Their system starts to shut down. So that's a hallmark of Lewy body, why it's very different. But again, let's look at the brain. Can you guys see this visual here, this brain with Alzheimer's? The normal brain looks a certain way, right? That's why you need a brain scan, because the brain shrinks when you have Alzheimer's, and the shape changes. So that brain scan is critical, because you can't just say this person has this because they're forgetting a lot. That brain scan is really critical, and it can actually show where the disconnectivity is happening. If you look at this, you can see very different looking brain. Not just a shrinkage, but that connectivity, like I was telling you all, it was like scrambled eggs, the way my father would take those tests and not be able to fill in the blank or draw a line instead of a circle. And there are other dementias. If you look here at the last thing, there's dementias that are associated with Parkinson's disease. And I know there's tremors and things like that in people's hands, like we were talking about the head trauma. And there's also, amazingly enough, which people don't know, dementia associated with the HIV virus and alcohol-related dementia and some of these other conditions that are degenerative that also have dementia associated. So one of the most important things, if you could take away anything when you think a person has this, is the first thing I did was took my father to get those basic tests from a psychotherapist or someone. And when she was able to document all of these tests that they do, and there's a lot of common tests for dementia screening, that at least got me to get the PCP to acknowledge that he had some problems. And then the next thing we knew, he had ran away and he ended up in the hospital and he got the scan anyway. So my whole thing is, a lot of people may not get that scan because it's costly and it's not something that a lot of insurance companies at times want to do, unfortunately. But it's so worth it because the resources that come with a confirmed diagnosis versus not knowing. So I'm going to stop there and see.
Dr. Bill?
Yes, ma'am.
Some of us didn't see the slide.
Oh, let me.
On the share screen, didn't see
Okay.
the umbrella or the brain.
Let me bring that umbrella back up. I think it faded out. So hold on 1 second. Let me bring it up because this is really important. Thank you for telling me that.
Mm-hmm.
Can you all see it now?
Yes.
Okay, so this is the umbrella that shows all of the different categories of dementia. So dementia is the umbrella term, like I was saying, and you can see here the most common is Alzheimer's. So can you all see this? There's a bunch of different things under this umbrella, but at the end of the day, dementia is the umbrella term and everything else fits under it. Thelma, does that make sense? Can you see that?
Yes, I can. Mm-hmm.
Okay. And then if you look at the brain, now you see the brain picture that I'm showing you, the normal brain, and then look at the brain with Alzheimer's. First of all, it's smaller, but you can see where there's that, what I call scrambled egg, where it's disconnected. Some of the links are disconnected. They've shrunken, but they're no longer connected. So you can understand why a person would draw a line instead of a circle, because they're missing certain linkages that would tell the signal to that part of the brain would tell them how to form that shape, but it's no longer there. So it makes perfect sense when you look at it this way, that a person, your brain has shrunk if you have this, and it really does need a scan to show this. You can't just guess that because they're forgetting something, they may have one of these, particularly because I didn't realize how many people in the family with diabetes probably had this until I started, surveying them and trying to help them. So this is really important. If there's nothing else that I can tell you about dementia and even Alzheimer's, it is trying to get them, if you can't get them to the doctor, because a lot of people are resistant, at least get them to somewhere where they can get the basic test done, and you can take that and take it over to the doctor, and they may or may not get a brain scan as a result of that preliminary, test where they have to remember certain things and day of year and certain things like that. And it does help get the approval for getting the brain scan. Is that helpful for you all? You probably already knew this or did not know it. Okay. I see one thing in the chat. Let's see. Okay, I think I'm done. So if anyone has any other comments or questions, just make sure you put your email in the chat so I can send you the recording as well as this entire presentation. And the third module, the last one that we'll be doing next week will be, of course, we'll do a recap, but it will also include a couple of case studies and all the resources that might be helpful. And if you have any resources, feel free to email those to me or, bring them to the table and we can upload those as well. Okay. Okay. I will stop sharing my screen and thank you all for participating today. So you guys can drop off and
awesome. Dr. Bill, did you get my message? This
yes, ma'am.
Hi.
Go ahead.
Hi, good morning, team. Very quickly, I think some of them are already starting to come off, but I want to give a few updates first. Thank you, Dr. Bill, so much. These presentations have been extremely thorough. I will send you the list of all of the staff members who are enrolled in this training program and their email addresses, so you'll have.
Great.
I did forward your first session PowerPoint presentation and the link of last week's video to everyone.
Great.
So everyone will send that information and I will forward that communication to you so that you can send it yourself.
Great.
You'll have that for the team, but all of this information is very, very, very well received. To the CDU Kedron team, please note tomorrow for our staff meeting, it will be very brief. As you know, we are scheduled to go to the Minority AIDS Project Community Give Back event for Giving Tuesday. That is scheduled tomorrow from 12 to 3, and that is an all staff event. And so the expectation is all staff members will be present to support that event, and we need to arrive by 11 to help get set up and get situated at the space. And so to that end, we will have an abbreviated staff meeting so that we can make sure that we're on time for the Minority AIDS Project event that is scheduled. Also, please note, and I'll go over this with you all on calendar, you will see that we have a special training. You did receive an email about that. I will share about it tomorrow. We have a special training for the Health Careers and Opportunities Program students at CDU and a presentation to go over our program with them that is from 12 to 1:30, where we'll allow them to practice doing some of the things that we do in street medicine, including registration, as well as the blood pressure, hemoglobin A1C, and cholesterol screening. So this will be an in-service but hands-on in-service experience for the HCOP students. So please check your emails today. I will verbally go over it at the conclusion of the partnership meeting tomorrow, which normally is around 9:15. We will have an abbreviated staff meeting so that we can make sure that we get to map on time for tomorrow. And so those are just the two things I wanted to cover with the team. And check your emails. You received this information of the holidays. I will resend it again so you'll have it. And then I look forward to seeing everybody on the partnership call tomorrow at 9 a.m. Those are the only things I wanted to mention, Dr. Veal. Thank you so much.
Thank you. And I'm sorry I couldn't see the chat. I'm not very good at manipulating both. So thanks to all of you. And I look forward to the final session. And I hope this was helpful. Take care and have a great day.
Thank you.
Thank you, Dr.
So
Veal.
much.
Thank you.
Excellent presentation.
Thank you, Dr. Davis. Bye.